I'm excited to be here with all of you. This is essentially why we do what we do. So thank you guys all for coming. I took the liberty I'm going to talk about a little bit more than just removing the primary tumor, given that Dr. Maluccio talked about the importance of what to talk about with your physicians, and Dr. Demir is going to be talking about the adrenal tumors. So we'll talk about a little bit of everything. But you've already seen the slide a few times, so we know that neuroendocrine tumors can arise essentially anywhere in the body. For purposes of this talk, we're going to focus primarily on the pancreas, the small bowel, and then a little bit on the liver. So we know that the incidence of NETs is rising. There's been multiple studies demonstrating this. Some of this is thought to be secondary to just better detection, but also there's also likely an increased incidence. I won't go into pathology because you've already heard about that in detail from Dr. Del Rivero. So again, most of what we'll be talking about is grade 1 and 2 well-differentiated neuroendocrine tumors. So most of this talk does not apply to neuroendocrine carcinomas, and it may occasionally apply to grade 3 well-differentiated neuroendocrine tumors. And I think this is an important thing to remember, that a majority of patients like yourselves who have been diagnosed with neuroendocrine tumors, by the time they get to me, a lot of patients have been dealing with symptoms for prolonged periods of time and have been dismissed in one variety or another. I can't tell you the number of female patients, especially, who were told that they have like IBS or menopause or some other things are going on, and their physician's just not listening to patients telling them there's something wrong. So you're in good company in the neuroendocrine group. It's not necessarily unique to you, and I think that's why it's important for you to help other patients advocate for themselves when they feel that something is wrong. What do you expect after your diagnosis? I think Dr. Chauhan, myself, and Dr. Del Rivero were sitting in the back and saying that in reality, your life turns into a new normal, right? So you've just been diagnosed with a type of cancer. We're telling you it's kind of like a chronic disease, that prognosis is good. You've just heard the C word. Everything stops. You're meeting lots of different doctors who are telling you many, many different things. But what's really important is that you really want to connect with a neuroendocrine tumor specialist, right? And you want to make sure that you can identify a team of physicians who are going to be available to you and for you during the course of your treatment, because this isn't so straightforward. I'm wearing a zebra shirt because, right, in medical school we learn when you hear hoofbeats, it's a horse, not a zebra. But neuroendocrine tumors are zebras. They don't behave like every other cancer. And you'll hear about that again and again and again if you haven't. But the important reason to connect with a NET specialist is because we have to give you a list of options, right? Surgery is not the right first step for everyone. It might be step number 10 in someone's case. It may have been step number 1 in someone else's case. Chemotherapy options, PRT, all the things that you're hearing. There's no perfect algorithm in terms of how we treat a neuroendocrine patient, right? It's not one size fits all by any stretch. And so if you identify a NET specialist, then you identify your team. Ideally, we sit down together in a tumor board, which Dr. Maluccio spoke about, and we figure out what is the best sequence of therapies for you. And that can change at any given time depending on how your disease may be behaving. And that's us huddling in a tumor board without faces. But the important thing is that if you meet the right team, then you should be able to feel empowered by your ability to make a decision, and you feel more comfortable and confident in trusting what your team is saying, because our job is to basically tell you why we're thinking what we're thinking. And sometimes the answer is, I don't know. I just think this is the next best step because, and we can work through it. So that's important. So our responsibilities as a physician is to provide easily understandable information regarding your diagnosis. If you have no idea what we just talked about after you left the office, I have failed. I should be able to provide you with a list of options. I should be able to give you the pros and cons for each particular option. And ultimately, we're working together to create a plan. It's not like do what I say or else. Your job, in order to make that worthwhile for both of us, is that you have to be completely transparent about your symptoms, your lifestyle, your goals, your preferences, and your past experiences. The reason I mentioned past experiences is because sometimes you'll say, you know what, I think we need to consider chemotherapy. And it'll be like, nope, my mom had chemotherapy, my uncle, my best friend, someone had chemotherapy and it was awful, I'm never doing it. Or, you know what, I had surgery, it was awful, never doing it. And that's an important thing to know, because what we might be treating you with might be completely different. The type of surgery you might be having is completely different. If any surgeon ever tells you that you're not going to have pain after surgery, that's a lie. So these are important things. And once we have this dialogue, then you can be open-minded. You need to be open-minded about the different treatment options. So what if you need surgery? Well, it depends, right? It depends on your recovery. What is that going to look like, et cetera, et cetera. It depends on the location and origin and the pathologic features. So some people may not be candidates for surgery for any variety of those reasons. The extent of your disease, right? If a patient has bony metastases and I tell you I can clear all of your disease, I can't, right? I'm not going to go in and take out all of your bone mets, but there's a possibility that I could clear your liver, I could clear your primary tumor, I could do lots of other things. So the extent of disease is important, and that's where the sequence of therapy becomes important. Your symptoms, whether your tumor is functional or non-functional, whether you have an obstruction, you're bleeding, you can't eat anymore. Those are all really, really important things that may not cure the cancer, but it's going to improve your quality of life. And then other factors, what's your overall health, right? If a patient has really bad cardiac history or horrific COPD or other things before this diagnosis even came about that made them a high-risk patient for surgery, that's something that we have to consider. We have to be able to make sure that we can get you through the process for there to be a benefit for you. And then the other thing we mentioned there is carcinoid heart disease. So some patients who have metastatic disease for prolonged periods of time can ultimately have heart issues secondary to the hormone oversecretion. And so sometimes we need to address your heart before we can operate on other parts. So that's kind of just the global background of when we're talking about surgery. The functional, non-functional you've heard about a few times so far. And we'll start talking a little bit about pancreatic neuroendocrine tumors. So kind of the standard of care approach in terms of when do we want to take them out is if they're functional. So if they're hormone producing, essentially any of the subtypes that Dr. Del Rivero just mentioned, you need to take them out because they're producing too much of that particular hormone and they can create a problem. Now, in some scenarios, you may have a functional pancreatic neuroendocrine tumor and you may have a large volume of metastatic disease. The goal is to try to do as much clearing of that disease as we possibly can with the goal of at least trying to get 70 to 90%. If we can do other therapies to diminish that overall load, that's obviously going to help. But if we go in and just take out the primary and leave 70% of the disease in place, you're still going to be overproducing that same hormone. So again, we didn't necessarily help you. So for a patient who has a localized pancreatic tumor, meaning it's just in the pancreas and nowhere else, and it's producing hormones, we take it out. If you have a non-hormone producing tumor, then generally for those patients, if the tumor is greater than 2 centimeters, non-metastatic, the standard of care is to remove them. And there's kind of a gray area when it's anywhere between 1 and 2 centimeters. And we'll talk about that a little bit. And then if you have a high-grade tumor, a well-differentiated grade 3 that's isolated, you can also consider taking those out. It's not always the first thing we do because we're concerned about those tumors rapidly going elsewhere, or if we can't see something, we're worried that you might have micrometastatic disease, meaning disease that we can't yet see. But in the event that we find those at a very, very early stage, we can consider surgery in those patients as well. So when I mentioned the 1 to 2 centimeter tumors, there's a number of different studies that have been published, essentially looking at what to do with these tumors when they're small. So you can see that in the graph at the bottom, it basically has the tumor size. So less than 1 to 1.5, sorry, I can't see, I think 1.5 to 2, et cetera, you get the idea. But as you go further to the right of the screen, the size of the primary tumor gets bigger. And what this is showing is that for small tumors, almost no patients have metastatic disease to the lymph nodes or elsewhere, right? So these are well behaved. They're small. The risk of surgery is probably greater than the risk of watching these. And so less than 1 centimeter tumors, we don't resect. 1 to 1.5, there's a slightly higher risk that you might have nodal disease or metastatic disease, but again, very, very small. As the tumor size goes above 2, that's when we see the predilection for these tumors to spread to other places or lymph nodes. And so that's why we routinely remove those. Now, we in addition to giving talks to you, we also give talks to doctors. And so one very famous pancreatic surgeon, when we were talking about these cutoffs, got up to the microphone and said, so you're telling me that if I have a patient who has a 1.9 centimeter tumor in their pancreas and they're 36 years old, I shouldn't take it out because it's under 2 centimeters. And we all just kind of looked at him and said, well, I mean, we had to pick a cutoff point, right? And the cutoff point happens to be 2 because that's how we measure them. Now, of course, in that gray area, that patient would be discussed in a multi-D tumor board if it was a localized tumor and 1.9 on the verge of potentially growing and the patient's 36, right? And we're not going to survey them for the next 70 years. Hopefully, you would consider taking that tumor out. So these numbers that I'm giving you, they're not like do this or else. But that's why the 1 to 2 is kind of the controversial zone. So current guidelines, like we talked about, observation for asymptomatic PNETs, meaning non-functional under 1 centimeter, resection for appropriate candidates with PNETs greater than 2 centimeters, and then individual decision for resection for patients with PNETs 1 to 2 centimeters. What about if you have metastatic disease? So you can consider cytoreductive surgery in appropriately selective cases. This means if we think that we can get a majority of the disease out, we would favor potentially doing that if it makes sense in terms of all of your treatment algorithms, right? And I'm again speaking in broad strokes. Typically, if you have metastatic disease with a pancreatic primary, we will favor some kind of neoadjuvant therapy. That might be PRT, that might be systemic therapy, that might be a somatostatin analog, just because we want to know kind of the biology of your tumor. The last thing we want is to do a big operation on you, and then on your first follow-up scan in 3 months, we see recurrence, right? Because we don't like that. You don't like that. So sometimes in those scenarios, that's important. In addition, where your tumor is in the pancreas is important because that determines the type of operation that you might need. And in the case of tumors that might be in the head of the pancreas, if you have liver metastases, if we do a procedure called a Whipple, right, whereby we take part of your stomach, we take the first part of your small intestine called the duodenum, we take the head of the pancreas, your gallbladder, part of your common bile duct, and then we do this reconstruction. So we reconnect all things together to the small intestine so that you can essentially have appropriate bile and pancreatic enzymatic flow. You can see that kind of in that last figure to screen right, you have a piece of small intestine that's connected to that green thing. That's the bile duct. So that means you have a direct connection with no sphincter of your intestinal contents and your bile duct, which goes into the liver, right? If we do that in a patient with a pancreatic neuroendocrine tumor, and you have multiple liver metastases, and you end up needing some kind of liver-directed therapy, arterial embolization, et cetera, there is a higher likelihood that you're going to get bad infections in your liver because the small intestine can have backflow of the enteric contents into your liver, and it can seed with bacteria that aren't supposed to be there, right? So sometimes if a patient presents with metastatic disease, and although we think we can clear some of the things, if we're concerned about a recurrence in that patient and you have a tumor in the head of the pancreas, we might say, hold on, we need to pause because doing this surgery may preclude you from future treatments, right? Alternatively, the red dot that's in the distal half of the pancreas, meaning, I think it says distal resection. So you see that blue and red thing? That's the SMA and SMV. That's essentially what separates the head from the tail of the pancreas, and that's kind of our anatomic landmark of what kind of surgery we need to do and if we can do it. A distal pancreas tumor, a little bit different. So if you do that, you're not really affecting any of the blood flow to the liver, and it doesn't apply to any future liver-directed therapy options for patients. And so in that scenario, you may consider doing a resection. Patients with distal pancreatic tumors also, they can sometimes grow rapidly. They push on the stomach. They can cause symptoms, et cetera, et cetera. So again, we can consider it. And this can be done minimally invasive, meaning laparoscopic or robotic versus open, depending on the size of the tumors. What about small bowel neuroendocrine tumors? So this is the most common site within the GI tract, and there's an incidence of about 10 to 12 per million. About 35 to 40% of patients will have multicentric or multifocal small bowel neuroendocrine tumors. What that means is that you may have been diagnosed because they found one main one, but in about 35 to 40% of patients, you'll have multiple additional small ones within a segment of small intestine. They're typically well differentiated, which means they're slow growing, but they frequently will present late because they're generally so small that they don't cause symptoms very often. And so by the time many people are diagnosed, it's either because they've presented with disease elsewhere. Sometimes there's an overproduction of hormones and you have the classic carcinoid syndrome. And sometimes they will cause symptoms. And there's some pictures from surgery coming up. So Because I don't know what the next slide is, I'm just warning you now. So just close your eyes if it looks scary. The standard of care for small bowel neuroendocrine tumors, because of that concept of multifocality, is that you have to palpate them manually. So when we do laparoscopic surgery, think of us operating with chopsticks, right? You don't have a lot of tactile feedback unless something is big enough. And we've certainly taken out some of these small bowel neuroendocrine tumors that are literally no bigger than 3 millimeters. They feel like a tiny little sesame seed. And yes, we can feel little things until I get too old, and then I won't be able to feel them. But I'll show you a picture. So the manual palpation allows us to make sure that we take out the entire segment of bowel and all the little tumors that might be there if you fall into that 35 to 40% range. When we do things robotically, we have absolutely no tactile feedback. So it's all visual. So you could see something if you're looking at it, right? Conceptually, like you push something and it doesn't move the way it's supposed to. It feels hard, but you're not actually feeling anything. So a lot of times this type of operation requires at least a small incision so that we can bring your bowel out and palpate it manually to make sure that we get everything. The risk of metastases to lymph nodes can be high. So the picture there kind of demonstrates that's a loop of small intestine. There's a tumor on it. And then you see those green things. The lymph nodes in real life are not green. I don't know why in every anatomic thing they're green. They're the same color as the fat sitting there. And so patients are like, why can't you just take out the affected lymph node? And the truth is I can't see it. You can see the blood flow, right? Goes to and from essentially where that small intestine is, and the lymphatics follow the trajectory of the vessels. So that tumor might be draining to those particular lymph nodes. So when we do a resection of the small intestine, we also take a swatch of mesentery, so that piece that has the draining vessels and the lymph nodes. And then those all go to the pathologist and they evaluate them. For a lot of different cancer types like colon cancer, small bowel cancer, like your standard adenocarcinomas, we have particular guidelines in terms of, in order to say we did the appropriate surgery, we need a certain number of lymph nodes that were removed, meaning we did an appropriate evaluation of that region. We don't really have that number in small bowel neuroendocrine tumors, but there have been studies that suggest that you should get at least 7 lymph nodes, because that's pretty indicative that you took a sufficient resection area. So here we go. These are the pictures. But this is a patient who had a laparoscopic assisted resection of a small bowel neuroendocrine tumor. So we identified the location where the tumor is, and then we make a small incision. It's really no bigger than about 4.5, 5 centimeters. You're able to bring the bowel up, and then we can manually palpate everything, and that's my hand. They're normal sized. And you can see where I'm squeezing. You can see like that little white imprint. That's a little tumor. So those are teeny, teeny, tiny. There's no way I could see that robotically. There's no way I could feel it laparoscopically or robotically. That's why the manual palpation is important. Cholecystectomy, a lot of patients will ask, do I need my gallbladder out at the same time if I'm diagnosed? If we're doing concurrent liver surgery, then frequently I'll remove the gallbladder. In patients who were going to require or are on somatostatin analogs, historically we used to routinely remove the gallbladder because we thought almost everyone developed cholecystitis, but the reality is about 30% of patients develop cholecystitis. So I've met a lot of patients who are like, please don't take anything else if you don't have to, and so we'll leave it behind. And then there's other people who are like, please take my gallbladder, and so we will. But essentially it's a discussion point that I'll have with the patient, and then we'll decide what needs to happen. This is a patient that frequently patients don't believe, and other physicians, when we're talking to them, don't believe about the multifocality of tumors. So this is a patient who had a mesenteric mass, so a bunch of lymph nodes, that area that's circled with the dotted line, those are lymph nodes that get all matted together and turn into a mass that we can sometimes see on CT. So sometimes that's how we diagnose small bowel neuroendocrine tumors, because we see a mass in the mesentery, but you can't necessarily see the primary, and then you get additional workup. But the neuroendocrine tumors themselves were teeny, teeny, tiny. And so once this was taken out, I had the medical student go to the back table and take a picture and then print it out on our printer that was immediately adjacent to the OR, and then put little arrows on it, and then we converted the arrows to the appropriate location on this thing. So everywhere there's an arrow, there's a little tumor. So this is an example of a multifocal small bowel neuroendocrine tumor, where the only thing you would have seen on a CT scan and the only thing we would have seen at the time of surgery if we didn't do the manual palpation is that mass. How do we approach these? So some years ago there was a description in terms of how we determine resectability for small bowel neuroendocrine tumors. So you can essentially see that there's 3 stages. So that main vessel there that's coming off the SMA, the superior mesenteric artery, it gives blood flow to the entire small intestine. And there's different branches, right? And the further away from the center that you are, the more likely it is resectable. It is easy to remove, because the way to think of it is on this cartoon image, right? That main vessel in the red where I have all the dots, you really don't want the mesenteric thing to be in the center of where that is. Because if I have to cut that, right, and it's involving the vessel, then I'm going to cut off blood flow to your entire small intestine. So that makes you not eligible for surgery, right? Whereas if it's further away from that central red line, the artery, the likelihood of surgery is higher. Historically, we used to think that we need to take the entire vessel that it's touching, but as we've learned more about these tumors, they're more pushers and not necessarily invaders. So they can cause a desmoplastic or fibrotic reaction, which makes everything really sticky adjacent to where the tumor is, but they're not always invading the vessel. They're not growing into it. So the other approach is, in that picture with the yellow fat, you can kind of try to peel it off of the vessel, right? So sometimes you will use that approach, and you'll try to preserve as much bowel as you possibly can. And if you can't, then sometimes even in those scenarios, you may consider cutting through tumor, which is never ideal, but these are extreme cases in which patients are having either severe symptoms, bleeding, obstruction. We need to consider bypasses. So again, not standard by any stretch of the imagination, but a consideration depending on what exactly is going on. Bottom line, regardless of the approach we take or what we need to do, the goals are always to try to get a complete oncologic resection. Oncologic resection means including lymph nodes, not just the small bowel tumor. You want to make sure that you do a thorough staging evaluation of the entire abdominal cavity. So when we go in there, we look and make sure that we're not seeing anything else. We're not seeing little kind of what look like salt granules that could be peritoneal disease, right? If you see those, you want to biopsy them. We look at your liver, we look at your ovaries, et cetera, et cetera, et cetera. So that's important. And then we want to optimize the safety for the patient. Make sure that, this is not an undertaking that takes 48 hours, because that's just too long for anyone to be under anesthesia. So it has to be reasonable, right? And improving your quality of life. With respect to localized disease, kind of like the pancreas, you can always consider resection. What about if you have metastatic disease? So standard of care, metastatic disease, you're symptomatic, meaning you come in and you're telling me that every time you eat, it doesn't go down, you're vomiting, you're in pain. That means you're symptomatic. Despite the fact that you're metastatic, it means you're symptomatic from your primary small bowel tumor. The guts are just like plumbing, right? If something is blocking stuff and it can't go from your mouth down, out of your anus the way it's supposed to, that's a blockage. If you're telling me that every time you eat, you have postprandial pain, meaning I eat, 20 minutes later, I'm in severe pain, I'm hunched over, et cetera, that's a symptom. So in those patients, if feasible, based on everything I just told you before this about where the vessels are, et cetera, we favor primary tumor resection. What about if you're asymptomatic? Well, that's controversial. So ENETS and NANETS guidelines and multiple other societies acknowledge that there's a lack of prospective evidence suggesting that we should do anything with asymptomatic patients. So we can't make any definite conclusions. Prospective evidence means, like when you hear about clinical trials, it's happening in real time. A lot of the data that I'm going to mention to you is retrospective in nature, meaning we did operations on patients 5, 10, 15 years ago, and then we said, hey, we have a question. Who did better, the patients we operated on or not, right? And we look back and I'll show you, the data says the patients we operated on did better. But the reality is we don't have all of the granular data in terms of why those patients were selected to have surgery, right? So it's not exactly controlled the same way a prospective study is. So that's the criticism of the different guidelines, right? And if you're truly not symptomatic, how is it possible to get better with surgery, right? So that's the big question in terms of the benefit of primary tumor resection. Now, my argument to that frequently is, are you asymptomatic if you have vague discomfort, pain, or food fear? Because a lot of times when patients are in my office, especially with these small bowel tumors, they've been dealing with this for 10, 12 years, and you'll say, well, does it hurt when you eat? No. Well, I mean, sometimes I feel a little bloated, and sometimes I skip, lunch because I don't feel so good after breakfast. And now, I went home, and then 2 weeks later they'll call me, now that you mention it, yeah, it's gotten consecutively worse over the last 2 years, but, I was just told it's normal. And so in reality, a lot of times, unless you question the patient and say, like, are you truly asymptomatic? Patients with small bowel primaries who have had them in place for a long time actually have symptoms, right? It's just you're waiting until things are horrible to tell me that something's wrong. And the reality is they've been not so great for a period of time. So these are real asymptomatic patients who claimed that they had no symptoms. I am not sure how the two on the right panel, I'm not sure how anything was passing through. You can see that area where stuff looks kind of balled in. There was like a pin-sized opening there. So there's no way that you had no symptoms. And then the other patient, you see how it's kind of darker in that one particular area? Well, that's lack of blood flow to that portion of the small intestine. So that's ischemia. That, again, the patient post-op said, oh, I haven't felt this great in years, which you don't recognize because you've been feeling so not great for so many years. So again, asymptomatic, I take that with a grain of salt. This is a study that showed that there's a benefit in symptomatic patients. We already talked about that. I don't think we need any more data. And then, as I mentioned, a careful history will reveal symptoms in about 50% of small bowel net patients who are classically described as asymptomatic. Most commonly, those will be abdominal pain, nausea, vomiting, weight loss. And these patients, I do think, actually benefit from resection of the primary tumor. Some will argue it's predominantly for progression-free survival and overall survival, which we also see on retrospective studies. But because they're retrospective, you have to kind of take that with a grain of salt. So how can resection of the primary tumor improve survival? Well, it can prevent obstruction that's bad enough where you end up in the ER and then we're doing an emergent surgery. Bleeding, bowel ischemia, that means lack of blood flow to that portion of the intestine, and progression of disease or carcinomatosis. Emergency surgery is not ideal. We frequently can't get rid of all the disease, especially if you've presented with a perforation. Then we're worried about an infection in your abdomen, et cetera, et cetera, et cetera. And then the big question that we can't answer, which is why we can't necessarily advocate for this every time, is what exactly is the risk reduction for obstruction, bleeding, or mesenteric fibrosis, right? So you would want to say, if we resect everybody who has a primary tumor in place in the small bowel, 1 in 4 patients will then not require X, Y, and Z. We don't have that perfect number. We do from a few retrospective studies, but it's not perfect. So these are a number of studies that looked at the benefit of small bowel and pancreatic resections in asymptomatic patients. All of them demonstrated for the most part that there was a benefit with progression-free and overall survival if patients had a resection of their primary tumor. All retrospective, no prospective data. This is one additional study that looked at 1,200 patients with primary tumor resection and compared it to about 560 without surgery. About 15% of the patients here also had simultaneous liver cytoreductive surgery. And again, the patients with primary tumor resection had an improved overall survival. Retrospective, but potentially a benefit. This was another study where we looked at our own data. So small bowel neuroendocrine tumors, better progression-free and overall survival with primary resection. And the majority of these patients were asymptomatic. So what is the benefit of primary small bowel resection? Certainly if it's localized, it could be curative. It can prevent future metastases, both local or distant. In the setting of metastatic disease, it can prevent or alleviate bleeding or obstruction and can reduce your circulating hormone levels. And in retrospective studies, it seems to improve overall survival. Do you want me to talk a little bit about the liver or stop? Talk about the liver? Okay. Okay. How do we manage liver metastases? So a number of different ways. We might use somatostatin analogs. We might use targeted chemotherapy, PRT, and then liver-directed therapies. So surgical resection debulking, in my opinion, is a liver-directed therapy. And then arterially liver-directed therapies, and then transplant in a very select group of patients. The 3 pictures I have there will show essentially 3 different types of patients who may have liver metastases, right? So the one on the top has 2 big lesions that are kind of peripheral in the liver that we can remove, right? That's a patient to whom I can say we can get a complete cytoreduction. Second patient, we can probably debulk a decent proportion, do ablation on some of the central lesions. The concern with that patient is that we're only seeing a little bit of what's happening, and I would be concerned that more tumors will develop in a short interval if we said, let's do surgery first, right? The patient on the bottom has more liver disease than they do healthy liver. So that's not a patient whom the type of debulking surgery that I could do would help. That patient may be eligible for a transplant if they fit specific other criteria, which are very, very, very selective. But definitely the bottom 2 patients would be eligible for creatide analogs, targeted chemo, PRT, and then liver-directed therapies, whereby we can target a number of those different lesions. So the next steps are dependent on the burden of disease in the liver. That's essentially what this slide is telling you. We will consider surgery for neuroendocrine liver metastases when we can resect all of the disease, or at least 70% of the liver volume. Again, these are patients with grade 1 or 2 neuroendocrine tumors, not high-grade neuroendocrine carcinomas. Patient has to be a healthy surgical candidate. We have to take into account what previous therapies you have had, right? Because the type of liver operation we do may render you with either a lot less functional liver, or we just want to make sure that you're overall healthy, and then your liver lab, so your bilirubin, your AST, ALT, all those things have to be within a certain range in order for us to feel comfortable doing that. Down at the bottom, I mentioned progression of a specific lesion. So it's not uncommon as we continue to follow you through this neuroendocrine journey that you've had liver tumors, they've been behaving perfectly well, and then all of a sudden one decides to go rogue, right? And so sometimes, although we can't cytoreduce all of the other lesions, or you may have been told that you're not a great surgical candidate, because that one is misbehaving, the assumption is that it could have a different biology, and sometimes surgery is an option for that one particular lesion. And that could be true for grade 3 tumors as well. So that 70% that I mentioned, that's based on some of the studies that have been previously done at the University of Iowa and Oregon, and Jim Howe and his group. And essentially they compared, if you debulked 90% of the liver tumor versus 70%, was there a difference in overall survival? And there really wasn't. So originally we thought you had to do a 90%, 100% debulking to start, because that's what we generally say to any patient with, for example, a colorectal cancer. Then it dropped down with a study by Mayo and his group to 90%, and then ultimately that was studied in the 70 to 80 was no different than 90% debulking. So 70% is kind of where we come up with that number. Progression-free survival is obviously better if you can get more disease out, but again, close between the 70 versus the greater than 90. And then what's important is the anatomy, right? So you may actually come to our office and you may have one small tumor, but it's sitting smack dab in the middle of the liver, right? In order to clear that one tumor surgically, if it's smack dab in the middle of the liver, because of the way blood flows in and out of the liver, we would have to take either the entire left or right side if it's right in the middle, right? Versus if a tumor is in the periphery. So if you look at that top panel, right, it's on the edge. So I would probably, in a neuroendocrine tumor, choose to do the furthest thing to the right, just kind of get right around it. Because like I told you, neuroendocrine tumors are pushers, not invaders. So a lot of times it's like if you think of a Jell-O mold and putting a grape into it, you pop the grape out and it's okay. The liver does fine. It's not really invading anything. But this is why sometimes patients will say, I don't know, I only have one tumor and they told me I'm not resectable, or I have 2 tumors and they said they can't do surgery. It's because it's probably in a location where it may not be safe or feasible for a variety of reasons, or we don't want to take out half your liver for a 1 centimeter lesion that's sitting smack dab in the middle, because we're worried that you're going to have other ones and then you only have 30% of your liver left, right? So that's an important consideration. The panel on the bottom shows a patient who has multiple lesions on the periphery, which if you look on the far right, you can remove everything on the periphery, and then that central bugger that I'm telling you about, sitting right in the middle, if it's far away enough from a vessel, then we can burn it. We can do an ablation. So although we're not going to cut it out, you still have other options. And in the setting of neuroendocrine tumors, we have liver-directed therapies as well. We have SBRT. We have all sorts of other options. So our goal as the surgeon is to get as much out and preserve normal liver function and as much healthy liver as we can leave behind. So this is an example who had multiple liver lesions. Like I told you, they're cored out, right? So we're not taking big chunks of liver with that particular tumor. We're just removing the lesions with a small negative margin. And then we can do ablation surgically. So this is us in the OR. We put an ultrasound probe on where the liver is. We can see on the screen with the ultrasound exactly where the tumor is deep within the liver, and then we put the probe inside and then we burn it with the ablation machine. This can also be done with CT or MRI guidance by our interventional radiology colleagues. Why surgery for neuroendocrine liver mets? Again, surgery can provide a potential for cure. That's always, of course, the goal. There is a potential survival advantage over no surgery, again, based on retrospective data. So the thought of resetting the clock. I always tell my patients that if you have liver metastases and we're operating on your liver tumors, your incidence of recurrence within 5 years in the liver is about 85%. That's a very high number, right? So it's very, very common that the tumors will recur in the liver if you already have them there. We just can't see them yet. So at the time of surgery, we also do an ultrasound to look and see if there's anything else that we haven't seen on MRI or CT that we remove or ablate those. But the cure group is a very, very small percentage. You can do a surgical debulking, and that has shown a benefit of progression and overall survival if you can get rid of 70% of the tumor burden. And then with newer techniques, we now know that we can basically not cut out half your liver for a small tumor in one area. So we can do tissue sparing or parenchymal sparing surgery, meaning we don't do these big resections. We leave you with enough liver so that you're eligible for additional future therapies. And then liver-directed therapies, I'm not going to go into because I think Dr. Maluccio spoke about those, but the basic concept is that the neuroendocrine tumors are frequently supplied by the hepatic artery, not the portal venous system, which is what supplies the normal healthy liver. And so a lot of times these catheter-directed therapies where our interventional radiology colleagues are able to go in directly into the hepatic artery. Sometimes they could find the direct feeding vessels into the tumors and block them off. So essentially you're starving them and they can shrink. And that's how liver-directed therapies, arterially directed liver therapies work. What about after surgery? So we just talked about 3 different types of surgery. Well, it depends on the type of surgery you had. So what type of the body? Nothing I just said is applicable to the lung because that's a completely different recovery. Which organs did you have resected? If we're just operating on your liver, I'm not so concerned about your gut function, right? I'm not so concerned about your pipes waking up again and things not leaking. How long was the procedure, right? Was it a 2-hour procedure versus a 12-hour procedure? That obviously is going to impact your recovery. Was it done open? Is the incision going to hurt more? Is it done laparoscopic? And then what was your baseline extent of disease and your overall health? I tell every single patient who sees me who's going to have surgery that before they have surgery, they have to walk at least an hour a day for at least a week before we operate. We talk about diet and exercise. Prehabilitation is really important because you're going to, regardless of what I do, to a degree, you're going to feel like you got hit by a truck the first day that you wake up. The last thing you want to do is move. So the stronger you are coming into a procedure, regardless of what it is, the faster your recovery is. And that's all I have. Thank you.